Hello everyone, welcome back. In today's session, we'll be studying jaundice of newborn, its types, causes, clinical manifestations, complications, diagnosis and management. So let's start. So see the headline, it also called icterus neonatorum, neonatal hyperbilirubinemia. So any of these three can be asked in exam. Now comes to first point. Yellowish coloration of skin and mucosa due to increased level of unconjugated or indirect bilirubin, toxic fat soluble bilirubin. Okay, so what is happening here? Yellowish discoloration of skin and mucus due to the increased level of unconjugated or indirect bilirubin, that is toxic fat soluble bilirubin. Now bilirubin is the product of breakdown of RBC. We know, right? Jaundice start from head, first seen on skin of face and later extend to chest, abdomen, arms and legs. Then jaundice appears last in palms of hands and soles of feet. So if you are seeing anyone that their palm and feet are yellowish, so basically it means that jaundice has been for so long period because it is coming at last, right? So that's why. Now comes to incidence. 60% in term and 80% in preterm neonate it is seen. Now types. See, physiological or normal jaundice. What is that? It appears after 24 hours of delivery in full-term newborn and after 48 hours in premature newborn. If it is preterm baby, then it will come after 48 hours. If it is term baby, it is coming after 24 hours. Then in term baby, maximum level at 4th day and subside by 7th day of delivery. So you have to remember, if you compare between physiological and pathological, so you should always have knowledge about the physiological first, then only you can compare with the pathological. Okay, now comes to next point. In preterm babies, maximum level at 5th or 6th day and subside by 14th day of delivery. And bilirubin level in mature baby should less than 10 milligram deciliter, or in preterm baby it is less than 15 milligram per deciliter. So for mature baby it is less than 10 milligram per deciliter, and for premature baby it is 5 gram more, that is 15 milligram per deciliter. Not present more than 10 days in term baby and 14 days in preterm baby. So by the end of 10 days it is resolving in term baby, and by the end of 14 days or within 14 days for preterm baby, and subsides spontaneously without any treatment. It is clear? Now encourage mother for exclusive breastfeeding for adequate hydration and excretion of bilirubin. So we have to teach the mother or encourage the mother for exclusive breastfeeding so that baby can stay hydrated and bilirubin also excreted by urine. Okay, now come to causes. So what are the causes now? Faster destruction of fetal RBC because their shorter lifespan 80 days and more HB level, that is 18 to 24 milligram per deciliter. So we know, right, because RBC is destructed faster in newborn because it has shorter lifespan, like around 80 days, but for adults it is 120 days, right? So, and also newborn, yeah, small baby is having more hemoglobin level, that is 18 to 24 milligram per deciliter, and decreased secretion of enzyme, that is glucuronide transferase by immature liver. Okay, because baby's liver is immature and this enzyme also secrete less, that is glucuronide transferase, and which is essential for excretion of bilirubin. Now comes to next point, that is insufficient intestinal common cell bacteria flora. So basically these three are the main causes. Hope you have understood. So let's come to pathological jaundice. So it appears within 24 hours of delivery and present for more than 10 days in term and 14 days in preterm. In physiological, we have studied that within 10 days in term and within 14 days in preterm, it was resolving spontaneously without any treatment. But in case of pathological, it is staying more than 10 days and more than 14 days. 5% newborn babies develop pathological jaundice. That was 70 and 80% was for physiological jaundice, but pathological only 5%. And bilirubin level increase at the rate of 5 mg per 100 ml per 24 hours. And bilirubin level more than 15 mg per 100 ml. Now comes to causes. That is, what are the causes for pathological jaundice? See, excessive and faster destruction of RBC due to Rh incompatibility or hemolytic disease of newborn. This is the commonest reason. And ABO incompatibility, that is rare. ABO incompatibility is rare, but Rh incompatibility is commonest. See, Rh incompatibility, also known as Rh isoimmunization or erythroblastosis fetalis, we have already studied. And Rh incompatibility occurs in Rh negative mother who carries Rh positive fetus during the second pregnancy. Now ABO incompatibility common in O group mother who carries A or B group fetus. In these three possible reasons it can happen. Now excessive destruction of RBC because excessive hemoglobin level and shorter lifespan and less production of glucuronide transferase enzyme by liver due to immature liver and deficiency of RBC enzyme, that is glucose 6-phosphate dehydrogenase, which causing hemolytic anemia. G6-phosphate dehydrogenase deficiency is an inherited disorder transmitted as an X-linked recessive trait. Okay. Now comes to clinical manifestation of jaundice. Start to seen at bilirubin level of 5 mg deciliter in neonate, because छोटा बच्चा है ना, तो उसका क्या है ना, 5 mg अगर बढ़ गया तो it is visible to that baby. So yellow is discoloration of skin of face and sclera. Yellow is palm and soles, clay or white color stool, then staining of diaper with urine. Only in pathological jaundice it is present. Now comes to complication. What all are the complication now? It is caused by unconjugated bilirubin, that is kernicterus. First, neurotoxicity caused by bilirubin. This is the pathological case. A pathological condition in which unconjugated free bilirubin, very toxic for brain, enters into the basal nuclei and cerebellum of brain. Cerebral cortex usually not affected. Okay, it is clear. Then it is manifested by lethargy, poor feeding, hypotonia, convulsion, opisthotonous position, poor or loss of motor reflex, and death also can happen. So this is manifested by lethargy, poor feeding, hypotonia, convulsion, opisthotonous position, poor or loss of motor reflex. Reflexes also we will study in later classes. So for now you listen to this. Now if baby survive complication like cerebral palsy and mental retardation may develop. Now bilirubin level increases up to 15 to 20 mg% or more. It is clear. Now comes to transient encephalopathy. What is that? That is, it is a transient and reversible neurological dysfunction, and recovery is possible with prompt treatment and exchange blood transfusion. So what is transient now? It is a reversible neurological dysfunction. Recovery possible है with prompt treatment and exchange of blood transfusion. Hope it is clear. Now comes to diagnosis. Serum level of bilirubin above 5 mg per deciliter. Clinical estimation of jaundice, visual assessment or Kramer's rule. What is that? See, bilirubin level, it is 5 mg per deciliter. It will be one level and only on face it is present. If it is 10 mg per deciliter, then we will mark as level 2. How we will understand? That is area above umbilicus. If it is area till mid thigh, then it is level 3 and 12 mg per deciliter. Then area till legs, level will be 4 and we will estimate like 15 mg per deciliter. Then if it is involving palm and soles, I have already told you that if palm and soles is coming late, so it will be more, right? So see, above 15 mg per deciliter, and this is the level 5. Now comes to management part. Management of jaundice, that is feed early to stimulate intestinal activity. So we have to start as early as possible the breastfeeding to the baby and to keep the bilirubin level low. Then prevent hypothermia, because hypothermia causes acidosis that interferes in bilirubin conjugation and excretion. It is clear? Hypothermia also will be discussed in next class. Now phototherapy or light therapy. It is started at bilirubin level of 5 mg per deciliter or more in preterm babies. Okay, a non-invasive method used for degradation of unconjugated bilirubin by photooxidation. Blue or blue-green, that is fluorescent or halogen light, it is used in phototherapy. LED or CFL light may use. Now this light through photooxidation degrades indirect fat soluble unconjugated toxic bilirubin to direct water soluble conjugated colorless and non-toxic bilirubin. So how it is working? The light through photooxidation, it is degrading the indirect fat soluble, that is unconjugated and toxic bilirubin, into direct water soluble conjugated and colorless and non-toxic bilirubin में transfer करते हैं. Hope you have understood. Then bilirubin absorbs maximum light in range of 420 to 600 nanometer wavelength of light rays. So we have to use within this range only, right? So daylight, that is white light, have wavelength of 550 to 600 nanometer. So it is less effective to blue light, that is 420 to 480. Okay, so better if we use the blue light. Now comes to complication of phototherapy. Hypothermia or hyperthermia, both can be happen. Dehydration, loose or green stool, then irritability and transient skin rash, bronze baby syndrome, hypocalcemia, all this will be the complication of phototherapy. Now comes to the techniques. What all are the different techniques for phototherapy? See, cover the genital area, gonads and eyes of newborn to protect from the radiation, because it may hamper them or some permanent damage also can happen. Now distance of light source should be 45 cm in fluorescent light and 35 cm in LED light, and also 20 cm in CFL light. So what will be the distance between light and the baby? So this is the 45 cm for fluorescent light, 35 cm in case of LED light, then 20 cm if it is CFL light. Then reposition the newborn at interval of 2 hours to expose all body parts. Fine. Now comes to next point. Administer more amount of fluid, mainly breastfeeding, to overcome problem of water loss during the phototherapy, because we have studied now that complication is dehydration. So we have to prevent that. That's why we are maintaining the more amount of fluid. Then passing loose green stool and green urine is normal phenomena after phototherapy. So if mother is panicking, we have to tell the mother that it is a normal, because your child is receiving phototherapy. It is clear? Then monitor for bronze baby syndrome. What is that? That is grayish brown discoloration of skin. We have to monitor for that. Then monitor temperature and breastfeed 2 hourly. We have to monitor the temperature because we have already studied the complication is hypothermia and hypothermia. So both is harmful for the babies. We have to keep monitoring the temperature. And also feed the baby 2 hourly. Then record body weight once a day. We have to record it. Then serum bilirubin level must assess at least every 12 hours. We have to assess the bilirubin level interval of 12 hours. It is clear? Then comes to medical management. So let's see, phenobarbital therapy. It increases the activity of liver enzyme, that is glucuronide transferase, which increases bilirubin conjugation. So phenobarbital, it is increasing the activity of liver enzyme, that is glucuronide transferase, which increases bilirubin conjugation. Then comes to cholestyramine, and charcoal may also used to bind with the unconjugated bilirubin in gut. Fine. Then exchange blood transfusion, that is when it is indicated, because see, indication is if direct comb test positive in Rh positive baby. Then unconjugated serum bilirubin level 10 mg per deciliter within 24 hours and 15 mg per deciliter within 48 hours. Is clear? Then rise in bilirubin level more than 0.5 mg per deciliter per hour, and serum bilirubin level more than 20 mg% in term baby and more than 15% in preterm baby. Then we are going for exchanging blood transfusion. Cord blood hemoglobin is less than 10 mg per deciliter. So these all are the indication for exchange blood transfusion. Now comes to nature and amount of blood transfused. Use Rh negative in Rh incompatibility or O blood group in ABO incompatibility. Fine. Then 180 ml per kg body weight blood is required to exchange 80 to 90% fetal RBC. Now what is the procedure? Umbilical vein and artery are cannulated to use for this procedure. Use pull and push technique, that is 5 to 10 ml blood pull and same amount push during the each time. So this is the basic procedure. Okay. 1 mm size catheter pass into umbilical vein up to 7 cm. See, 1 mm size catheter pass into umbilical vein up to 7 cm. So catheter reach to inferior vena cava. Then calcium gluconate should be injected after every 50 ml of exchange to prevent tetany. So this is the procedure. We are cannulating the baby in umbilical vein also and umbilical artery also. We are using pull and push technique. What is that? That if 5 to 10 ml blood is pulling, same amount of blood we are pushing during each time. Then 1 mm size catheter pass into umbilical vein up to 7 cm. So the catheter reach to inferior vena cava. Now calcium gluconate also we are injecting after every 50 ml of exchange to prevent tetany. So this is information about jaundice in newborn. So hope all the point is clear to all of you. See you in next video. Thank you.